Hello, everyone. My name is Gab McDonough, and I'm the Educational Action Supporting Officer at ERN-EuroBloodNet, and I'm happy to welcome you to the sixth session of GenoMed4All, an ERN-EuroBloodNet educational program on artificial intelligence in hematology for an expert audience. On that note, I'm happy to introduce our speaker for the sixth session, speaker Marina Martello, and the topic is use case overview of results from both a technical and clinical perspective, plus specific onboarding requirements, for example, minimal data set. Marina Martello is a researcher at the Institutes of Hematology at the Seragnoli Department of Medical and Surgical Sciences at the University of Bologna, Italy. She is a member of the molecular biology lab group, mainly involved in translational research of lymphoproliferative diseases, particularly focusing on genomic and immunophenotypic characterization and minimal residual disease analysis by means of the most innovative approaches such as artificial intelligence and liquid biopsy. So with that introduction, I hand off the floor. Thank you very much for joining, Marina. The floor is all yours.
Thank you, Gavin. So we can start with the presentation. In today's presentation, we will have a brief introduction on multiple myeloma, so the disease that is the object of this part of the GenoMed4All project, and we will see some new insights about clinical and the biological context of the disease. And in particular, we will see the current risk definition of the disease and the last update that are the Barcelona criteria. And then we will see some examples that have been published in literature recently about the artificial intelligence implementation in multiple myeloma. Then we will move to the core part of the presentation, that is the multiple myeloma use case in the GenoMed4All project. And so we will see the data set that have been provided in the context of the GenoMed4All project. And in the third part of the presentation, we will have an overview of the results produced in the context of the GenoMed4All from the different partners of the project that are the Universidad Politécnica de Madrid, University of Turin, and the University of Bologna. So starting with the introduction of the disease, maybe you are aware that the multiple myeloma is a plasma cell disorder, and there are no unique marker that define the disease. So the biology of the disease is very heterogeneous, and it is characterized by a clinical outcome. So patient, as you can see from this slide, patient after receiving therapy might have a decrease of tumor cells. So patient can be characterized by different level of residual cells, and so the clinical outcome might be influenced by the quantity of the residual cells and the persistence of these tumor cells. So patients, even though the new therapy are very effective, they experience relapse due to the persistence of these tumor cells. So the biology of the disease is so complex because it can be resumed by 4 different layers of heterogeneity. So multiple myeloma might have an intratumor heterogeneity, so the plasma cells can be very heterogeneous inside one patient, but it can be also different from one patient to another. So the disease from a biological point of view can be very different from one patient to another one. And 2 other factors can complicate this picture, that are the time and space, because recent insights in the last years have highlighted that multiple myeloma can change over time. So the biology that we know at the diagnosis of the disease might be different when the patients experience relapse, and also can be different in space. So we know from, in particular from the latest studies by Leo Rasche, that if we study in particular the different lesion different from the bone marrow, so other lesions that are spread into the body, this lesion can be different in the molecular at molecular level from the lesion present in the bone marrow. So the current multiple myeloma risk stratification scores that are illustrated in this slide are used in this moment in order to predict the risk status of the patient at diagnosis. Unfortunately, this current risk stratification are able to stratify only a small portion of high-risk patients, approximately around 20%. And they use, in particular, these are the latest published in literature, and they use genomic feature and also serum features. We know that we know from literature, from recent studies, that this current risk stratification are quite suboptimal because they can identify a risk patient, but also among the standard risk patient, some patients experience, for example, relapse, early relapse. And so it is known that the risk, the status risk of the patient might be defined, but by study also other characteristics different from the serum, the genomic studies so far. As you can see from this slide, indeed, we can consider also the circulating plasma cells, or for example, gene expression profile, and so on. So what we know so far in multiple myeloma is that the current use risk stratification are suboptimal. In particular, regarding the genomic panorama of lesions in multiple myeloma, there are it is very challenging to define which are the high-risk feature and the co-segregation of these different features, since they are very in the current risk stratification are studied by FISH, and the new methods have been included very recently. So it's very difficult in this moment to define the importance of the co-segregation of this alteration. As you can see from this slide, this is one of the latest studies published in literature, and you can see that patient can be characterized not only by a single alteration, but not by a single alteration, but from a list of alteration that happens together in the same clone. This is the latest, in this slide you can see the latest release of consensus stratification that again did not take into account of the whole genomic heterogeneity that we have seen in the slides before, because it takes into account, it consider the study of the TP53 gene by sequencing, because it's renowned that not only the deletion, so the copy number, but also the mutation on the gene are very important, but only some segregation are taken into account, and it considers only the genomic heterogeneity of the patient. So what are, in this moment, based on this observation, the possible area of improvement in order to define this unmet clinical need in multiple myeloma that are represented by this high-risk patient? So the possible solution are represented by, of course, the improvement of multifactors integration, the improvement also of the timing when we want to define the risk, to assess the risk of the patient, and also a consideration should be done also on tumor size. For the scope of today's presentation, I will talk about multifactor integration, and in particular, we can improve the consideration of multifactors in order to define the risk of the patient by implementing artificial intelligence and also deep learning systems in order to develop decisional algorithm to be used to improve patient management. In this moment, there are two excellent experience of the implementation of this kind of method in literature, multiple myeloma. The first one is resuming this slide, and authors have used a machine learning model in order to predict those patients that are that more easily reach the undetectable MRD status. And the innovation resides in the fact that this author consider very a wide list of features present at the diagnosis of the patients. And these features derive from very different kind of experiments and are data derived from a wide range of experiments such as phenotype data, genomic data, serum data, and so on. So by considering this wide range of data, they are able to predict with high confidence the probability to reach the undetectable MRD status that is beneficial for the patient. The second example in literature that use this machine learning method has been published recently, and consider a high number of experiments that use omics method, and it consider a high number of newly diagnosed multiple myeloma, approximately 4,000. And in this paper, the author demonstrated that it can be created, so this new algorithm called IRMA, for estimating the individualized risk and treatment variance for newly diagnosed multiple myeloma. And this tool is also available for the research community online in order to predict the response of a specific patient to a specific treatment. So in the context of GenoMed4All project, and in particular in the multiple myeloma use case, our aim, based on the premise, on the previous premises, is the following research question. So can we identify predictors of early relapse? So those features that can predict early relapse of a patient, so within 12 or 18 months from the start of therapy, based on the integration of this different nature of data, so genomic, clinical, and imaging data. To this purpose, our group here in Bologna provided for the project, for the aim of the project, two kinds of data set, the so-called Bologna data set that include 253 newly diagnosed multiple myeloma patients, mainly treated by a proteasome inhibitor-based triplet therapy at the induction. And these patients are patients also that underwent two autologous stem cell transplantation. Usually they receive a consolidation therapy and then a maintenance therapy. For this data set, we provide three different kinds of data. So the genomic data that include 79 features derived both from two kinds of genomic method that are SNP array and ultra-low pass whole genome sequencing. And also clinical data have been provided that include 60 features, such as biochemical, response to therapy, and also survival data. And finally, imaging data that include the PET-CT scans and also the PET data annotated by the clinician. On the other side of the slide, you can also see the second data set that we have that we provided for the scope of the project. That is the COMPASS data set. This data set is freely available online based upon a request, and it includes 1,144 newly diagnosed multiple myeloma patients with both genomic and clinical data. It does not include imaging data, and all the data have been downloaded from the site indicated. So 2 steps have been figured out by our group in Bologna in this for this data set. The first one was a data set harmonization, since particularly for genomic data, they derived from different molecular techniques. So the output data were very different. So this step was very important in order to provide to the other research group a clean data set to perform the downstream analysis. So during this harmonization, for example, all the information provided, for example, for amplification or deletion of a specific chromosome have been annotated all in the same way. So the one derived from the Bologna dataset and the one derived from the COMPASS dataset all are being annotated in the same way. And the second step that have been done by the Bologna group regarding also the pipeline for the genomic data processing. The pipeline is illustrated in this slide, and for this pipeline deposition, the pipeline has been optimized and also uploaded to the Syneca platform. And as you can see, this pipeline consists in a first part of pre-processing of genomic data. This pipeline permits the process of the FASTQ file that you receive in output from the genomic analysis. And in the second part, when you obtain the BAM files with this pipeline, you can do a post-process of the file in order to obtain the table file that contains the copy number variation data. All this pipeline have been optimized and uploaded by the Bologna group in the Syneca platform, and it is available and to be used for other genomic data. So the ongoing analysis in the context of multiple myeloma use case are mainly 3 in this moment, and regarding the federated learning, where the University Polytechnica of Madrid have released some data, then the data modeling and the machine learning training algorithm for risk prediction, and we illustrated some data from the University of Turin. And also the last part regarding the radiomics, mainly performed by the University of Bologna. Regarding federated learning, the group headed by the Professor Santiago Bello from Madrid I've used the dataset, the Bologna dataset and the COMPASS dataset in order to define the possible implementation of federated learning in a real context. So the federated learning, also known as collaborative learning, is a machine learning technique that can train an algorithm via multiple independent sessions. And each of these sessions can use its own dataset without sharing data. So to this purpose and for the next future possible use of this federated learning, we discussed the dataset with the UPM group in order to help us in order to select the feature to be used for the downstream analysis. Then the synthetic data have been generated by UPM and then validated. In the first part of dataset discussion, dataset have been further cleaned, and the work of federated learning have been done on a final dataset of 1,030 approximately patients. The synthetic data generation have been done through a machine learning model that is a variational autoencoder model that is able to train 15 different seeds. And the model, as you can see from this slide, is also able to generate a missing value mask that can reproduce the real-life situation. And after generation, these synthetic data have been validated also to test their validity. And two specific parameters have been used in order to test the utility of this synthetic data. In particular, the survival analysis, and in particular the C-index and the classification in order to predict the early relapse. And as you can see, both the completed data and the incomplete data demonstrate good performances. In the last part of the validation of the possible scenarios produced by this model, some preliminary data have been produced in this context, and one of the most interesting results is that the federated learning in this case can be especially recommended in the settings where some data might be missing. That is the situation that was reproduced the real life situation. Also in this context, further analysis are ongoing in order to validate the final results. In the second part of this overview or results in the context of the GenoMed4All project, these are results produced by University of Turin and regard the data modeling for risk prediction. In particular, as you can see from this illustration, the Turin group have used the CMV data, so the data derived from copy number alteration, and they always use a variational autoencoder machine learning model in order to predict the risk of a particular group of patients obtained by a k-means clustering. The model have been trained in the COMPASS dataset, in particular on 837 patients. So as you can see from this graph, from this UMAP plot, 4 different clusters have been identified with a specific C index. These clusters have been further characterized by the presence of specific copy number alteration that are shown in this plot. And once the model have been trained on the COMPASS dataset, it has been further validated in the Bologna dataset. And as you can see from this UMAP, the Turing group have still identified the 4 clusters similar to the COMPASS dataset, and in particular these clusters have been characterized by the presence of specific copy number alteration. For example, the cluster 1 is characterized in particular by the presence of 1q and deletion 13q. And both datasets have been further characterized by further analysis have been performed in order to verify which are from this analysis the genomic feature and the clinical feature that best predict for early relapse. And as you can see from this graph, both the COMPASS and Bologna dataset display a similar outcome in the variability of every feature in determining a specific risk. In particular, for example, we can see the protective effect of the transplant, of having received or not the transplant, and also the effect of every single genomic alteration have been analyzed. And as a clinical outcome, we can see that from this analysis we can outline a specific outcome for every cluster we have identified. And we can see from these Kaplan-Meier curves that patients, particularly deriving from cluster 1 and cluster 2, have a particular worse prognosis with respect to the other cluster identified by this analysis. The last set of results obtained in the context of GenoMed4All multiple myeloma use case regarded radiomics. In this last part of the project, data have been produced by the University of Bologna and the group of Professor Castellani, and are the process of data analysis have been illustrated in this image, in this schema. And as you can see, data have been obtained from more than 200 patients, newly diagnosed multiple myeloma patients, for whom we have provided both the clinical data, the genomic data, and also the PET-CT scans. These images have been further processed by the University of Bologna, and in particular, some data have been further processed, such as the volume of interest of the lesions. Sorry, I lost the slide. Okay. Particularly for the volume of interest that describe every specific lesion, and also the extension of each specific lesion. Once the images have been obtained, for each images, features have been extracted, and in particular, three kind of features have been extracted. So features of the so-called force order, the shape, and also the texture of the images. And in this specific moment, several survival analyses are ongoing in order to define which of these features from extracted from the images are the most useful in order to predict the outcome, and in particular the early relapse. In this slide, indeed, you can see all the steps that have been accomplished in order to process the radiomic images, and in particular also to obtain intensity data also from osteolytic lesion, and not only from the tracer captation derived from PET. So each kind of data have been provided in the context of this analysis. Okay, so based on this overview of results, we can conclude some analyses are still ongoing, and the further data will be released in the next month. And so to wrap up the information that we have seen so far in this presentation, we have seen that multiple myeloma is a complex disease, but for sure it still needs a cure. There is a strong need to interconnect different kind of data, such as biological data, clinical data, and also imaging data, in order to predict the patient's risk. A precise prediction require, as we have seen, a huge amount of curated data, so data that have been also harmonized in the first part of every project, in order to be statistically significant and possibly clinically meaningful. The artificial intelligence can help in this data management, also for the interconnection and prediction of the aim of the project. With the partner of the GenoMed4All project, we aimed at the integration of these different kind of data in a large cohort of newly diagnosed multiple myeloma patients, in order to identify the predictors of this early relapse that can also refine the definition of high-risk patient. So in the future, these results will contribute to an improved design of clinical trials, and also a better patient management towards a more precise medicine. So in this last slide, I would like to thank all the people that have contributed to this work, and in particular the Bologna group, the Molecular Biology Lab, the Clinical Research Unit, and the Nuclear Medicine that have contributed to the PET data, and also the group of Professor Castellani, the group of Universidad Politecnica de Madrid, and the University of Turin, the Professor Piero Farisalli. And thanks all of you for your attention.
Great, thank you so much for your excellent presentation and for your time and expertise. Perhaps we can have a quick look and see if there are any questions that have come in.
Okay, so the first one is, would there be an opportunity to contribute to the Bologna Compass
Okay, so I can read the question.
Okay.
So the people can hear. Okay, so yeah. The The first question is, would there be an opportunity to contribute to the Bologna Compass dataset? Do you offer the harmonization integration support for external data? So in this moment, I think that the dataset can be expanded, and there are a lot of efforts have been done in this perspective. And in particular, as I told you during the presentation, the Bologna group have uploaded, for example, the pipeline of genomic data processing. So there is data can be expanded, and people can get in touch with Professor Castellani or Dr. Carolina Terragna in order to ask for how to figure out with the implementation of your data. So the second one, thanks for the presentation. You mentioned the genomics pipeline have been already published. Is it open public resource? Okay, so the same one as I told you before. So it is uploaded in the Cineca platform. So it is available for the scientific community. And if you have also any additional question, you can write. And you can ask to Professor Castellano or the Bologna group in order to have some collaboration in that way.
Great. Thank you so much for the questions from the audience and for your answers. It's been a real pleasure to be a part of this GenoMed4All and ERN-EuroBloodNet program on artificial intelligence. And this program wouldn't be possible without the generous support and expertise of experts like yourself. And I would like to take a special moment and thank my colleague Diana, who has been very instrumental helping with everything, and her colleague Alexandra. And if there are no more questions in the chat, I'd just like to thank you once again, and we hope to see you at future webinars as well. So thank you once again.